Good morning. It's 8:30. We've got a packed session for late-breaking clinical trials 2024. The beginning of this is in Incheon, but it actually could be in Amsterdam because it's really a recap of what happened at ESC. And so we're excited for an action-packed late-breaking clinical trials 2024. I'm here with my co-moderator, Bruno Scheller. Amazing panel that we'll introduce one by one as we actually go through and have discussion about this.
So it's my great pleasure to introduce Ziad A as my co-chair, and here's the first presentation on the ILUMIEN 4 trial, OCT versus Angio-guided PCI.
Thanks very much. So as you all know, OCT-guided PCI versus angiography-guided PCI was a study that we conducted as part of the ILUMIEN series of trial. This was the largest ever randomized controlled trial comparing OCT guidance to angiography guidance. So as you all know, PCI is most commonly guided by angiography alone. However, angiography has well-recognized limitations. They can be overcome by intravascular imaging guidance. In ILUMIEN 3, we showed that OCT guidance could actually improve procedural outcomes by reducing greater major malapposition and major dissection and getting you a bigger stent area and stent expansion. But whether those procedural outcomes could improve clinical outcomes remained unknown. As a result, we conducted the ILUMIEN 4 randomized controlled trial. In this trial, we focused on high-risk patients and high-risk lesions, the idea being this was where we thought you could actually get the most bang for your buck, meaning you had the most likely to show a benefit between groups. Patients were randomized 1-to-1 to OCT guidance to a specific strategy and optimization protocol, similar to the MLD Max protocol, or in the angiographic-guided group standard of care. Uniquely, in ILUMIEN 4, we actually had a blinded OCT performed in the standard of care arm, and the reason for this was it allowed us to assess acute procedural outcomes and then tie them to the mechanism of potential for the primary clinical endpoint. Patients were considered high risk if they had diabetes or if they had an acute coronary syndrome, and high-risk lesions were considered long or multiple lesions where you had a total stent length greater than 28 millimeters, really based off of work that was done here from IVUS-XPL, diffuse or multifocal in-stent restenosis, angiographically severe calcium, chronic total occlusions, or a bifurcation planned with 2 stents, dissimilar from the October study. The primary imaging endpoint was the post-PCI OCT-assessed minimal stent area in both groups, and the primary clinical endpoint was the 2-year rate of target vessel failure. Safety endpoints included stent thrombosis and procedural outcomes. These were not powered. In total, we randomized almost 2,500 patients between OCT and angiography. We had 1,147 patients in the OCT arm for the primary imaging endpoint versus 1,201 in the angiography endpoint, and almost all patients had complete follow-up with a very small amount of loss, and finally, all of them were analyzed by intention to treat for the primary imaging endpoint. The baseline characteristics were similar between the two groups, and the qualifying characteristics identify that many of the patients were diabetic, as we expected. The most common lesion indication was actually a long or multiple lesions, followed by an ACS, followed by angiographic severe calcification, ISR, CTO, STEMI, and bifurcation with 2 planned stents. Please understand that these are not mutually exclusive. You could have a medication-treated diabetes patient who has a bifurcation planned with 2 stents. In terms of angiographic characteristics, the difference between the two groups was really a longer lesion length in the OCT-guided arm. In terms of procedural characteristics, you'll note that the OCT-guided arm led to a longer stent length, very similar to most intravascular imaging, averaging about 3 to 4 millimeters in length. The minimal and maximal stent diameter was larger, post-dilations were used more frequently, maximum inflation pressure was higher. The cost of performing OCT was a longer procedure duration, more fluoroscopy, more radiation, and more contrast. Of course, note that patients had to have multiple runs of OCT because we had a primary imaging endpoint. OCT led to a larger minimal stent area by about 0.4 millimeters squared, meeting the primary imaging endpoint of the trial, and correspondingly there was larger minimum stent expansion and mean stent expansion, and as a result greater acute procedural success, which was defined as an expansion of greater than 90% in both sides or halves of the stent. In terms of the procedural OCT outcomes, OCT led to less dissections, less major malapposition, less tissue protrusion or major tissue protrusion, and less focal reference segment disease. It also led to angiographic complications that were reduced by the core laboratory, largely due to a reduction in thrombotic events between the two groups. Very importantly, catheter-related complications, which are sometimes cited as a reason that people don't perform intravascular imaging, was extremely infrequent. However, the primary clinical endpoint was not difference between the two groups at 2 years, 8.2% in the angio-guided arm versus 7.4% in the OCT-guided arm. The hazard ratios for cardiac death favored OCT guidance, but not statistically significant. The hazard ratio for target vessel MI favored OCT, but not statistically significant. As you all know, most randomized controlled trials of imaging guidance are largely driven by a difference in ischemia-driven target vessel revascularization, and we saw complete equipoise in this group in the 2-year clinical endpoint. We did see a very large and extremely meaningful reduction in stent thrombosis. You'll note that after the acute procedure, almost no patients received or had a stent thrombosis after the immediate hospitalization. You'll notice also that death or MI occurred within 2 years in almost all of the patients who had a stent thrombosis. You'll notice on this slide that the hard endpoints of cardiac mortality, all-cause mortality, target vessel MI, periprocedural MI, all had numerical favoring of OCT with trends towards benefit, but the equipoise in all revascularization and its component was really what drove the differences. We did not find differences in the subgroup analysis, and we feel like this was actually impacted by COVID, specifically because if you look at patients who achieved at least 1 year of follow-up, prior to COVID, the hazard ratio was exactly where we powered the study to be, but during COVID, due to a halving in the number of ischemia-driven revascularizations from 8.1% to 4.1%, those lines converged. We did find a very meaningful relationship between the minimal stent area and clinical outcomes. When we looked at the independent predictors of ILUMIEN 4 for target lesion failure, you'll notice them to be minimal stent area and proximal edge dissection. For cardiac death or target vessel MI, again, a minimal stent area and your stent length. For IDTLR, intrastent flow area, which is collinear with minimal stent area, proximal edge dissection, and a borderline tissue protrusion, and finally stent thrombosis. This is the most important slide from ILUMIEN 4. What it shows you is that when you put in a small stent, you have the maximum amount to gain by performing imaging guidance. When you put in a big stent and you end up with a large minimal stent area, the target vessel failure for these patients is exceedingly low. What that means from a practical point of view is when you're putting small stents in, the gain that you yield from using intravascular imaging, a small difference in a small area makes a huge difference to your clinical outcome. So when you're imaging these small vessels, not the proximal LED, it's actually the distal part of your stent if you put in a 38 is what drives the clinical outcome. And you'll notice that there's a dramatic and exponential increase in target vessel failure after a minimal lumen area of 4 millimeters squared or less. Take home message, image your small vessels. So in conclusion, OCT guidance resulted in larger MSA than angiography guidance with greater stent expansion. There was fewer dissections, major malapposition, major tissue protrusion, untreated focal reference segment disease, and OCT guidance reduced angiographic complications, but did not reduce 2-year rates of TVF. OCT did significantly reduce stent thrombosis, an important clinical outcome, and there were trends towards the hard endpoints being beneficial, but rates of TVR may have been lower than expected because of the impact of COVID. And finally, the most important OCT-derived post-DS predictors of safety and effectiveness were related to stent area, expansion and flow, proximal edge dissection, and stent length. Thank you very much.
Thank you. Great talk. We stay in the comparison of OCT and angio-guided PCI now in the October trial in bifurcations. We heard about in the previous session. Niels Holm, please.
Thank you very much. Thanks for the kind invitation. My disclosures. So the October trial, we focused on bifurcation lesions. We already knew at the time that treatment of bifurcations were associated with worse prognosis. We now know it's in terms of increased mortality, and still in contemporary PCI, for example, as seen in the e-Ultimaster registry, very large, more than 300 centers. Myocardial infarction, TLR, and stent thrombosis are still increased with bifurcation PCI. So we already knew also at the time that as soon as we start to do something for the side branch, we get into trouble. There's a very high rate of these cases that are suboptimally performed, and that led to the protocol for the October trial, focusing on cases where you needed a one-stent strategy with kissing balloon inflation or two-stent strategy. There should be a good room for optimize these cases. So we had the pleasure to work with 38 centers across Europe on this, and we had a protocol where we provided initial on-site training for all sites, and then feedback on all the OCT-guided cases for continuous learning throughout the trial. So we ended up randomizing 1,201 patients with true bifurcation lesions, either to this OCT guiding protocol or angiographic guiding. And the angiographic guided arm, IVUS, was optional for left main treatment, and 16% of the cases were actually guided by IVUS, which corresponds quite well to the use in Europe in general. And then we had a primary endpoint of 2-year MACE. So the trial design, we had got quite a number of questions why we had so many two-stent techniques, but the trial was designed to have first a fraction of one-stent cases, so the physicians got familiar with the protocol, use of OCT. In Europe, we don't have the level of experience in most centers as you have in, for example, Korea and Japan. So it was kind of training within the trial to have first one-stent techniques, and then we went on to include two-stent strategies, and we could see most of them were QLOT and DK crossed, and some TAP and T stents. So for the power of the trial, it was we asked for this. We also asked for a good fraction of left main cases. We didn't actually get that much. We had 1/5 of the cases were in the left main. So the primary endpoint of 2-year MACE was significant in favor of OCT-guided PCI with a hazard ratio of 0.70, so a 30% risk reduction after 2 years. The patient-oriented composite endpoint was directionally in favor of OCT-guided PCI, but not significant. It was a secondary endpoint. And to put the trial in some perspective, this was a meta-analysis. I had the pleasure to work with Ziad on this work led by Greg Stone, published 2 months ago in The Lancet. And if you can see the October trial here, the point estimate for the primary endpoint is exactly the same as the overall estimate for the entire cohort of almost 16,000 patients. So when we look at the individual endpoints, so they are all insignificant in the October trial. It was not powered for that, so as we just saw with the ILUMIEN trial, they were all directional in favor of OCT guiding. And if you look at the meta-analysis estimates compared to the October trial estimates, we made a very good contribution, very strong contribution to the overall meta-analysis estimate for all-cause mortality, cardiac death, and ischemia-driven target lesion revascularization. So the main message is, of course, that with imaging-guided PCI, you can reduce mortality and also the other individual components. If we look at the October trial subgroup analysis, there were no interactions, but still some important messages. We have for the left main group had the same effect as the non-left main cases, but we also had 30% of the cases in the angio arm guided by IVUS in the left main versus 10% in the non-left main cases. So despite 30% IVUS, we still had a quite good effect of routine OCT guiding in the left main cases. So we also had a bit of surprising finding that one-stent techniques had a really major effect of imaging guiding, whereas two-stent technique was not that prominent. But as I explained before, we started out with one-stent techniques, and then we went on to do two-stent techniques, and unfortunately that corresponded with a pandemic. So we asked physicians to do very long, complex two-stent techniques with imaging guiding and further optimization, a lot of pullbacks, while everybody else told them to do very short procedures while they were in full protective gear, and they wanted the patients out of the cath labs as fast as possible. So we could see that the procedural quality went down, and also that both because there's pressure, but also because we have long pauses in enrollment at that time due to the cath lab simply closed for research. So, so this may have affected, we could clearly see that in the core lab, that it affected the two-stent technique. So we had exactly the same effect as Ziad showed, that the number of cases that came in for angiographic evaluation with events went down. So many patients were managed medically. So we have a drop in target lesion revascularization during COVID. And then we had this drop in the procedural quality as well. So that may have affected the trial. So that we still have a positive trial indicates that we have a really strong effect in OCT-guided. Had we stopped the trial at the day COVID started, we would have had a massively strong positive result of primary endpoint of the October trial. But we lost a bit of the effect during COVID. So a note also from the previous session, if you have long side branch lesion lengths, these are the high-risk patients. We also know that from the definition registry, and also the same here in the October trial, the effect of using intravascular imaging if you have long side branch lesions is really high. So in conclusion, OCT-guided PCI was associated with lower incidence of the composite endpoint of 2-year MACE than angiographic-guided PCI in treatment of complex bifurcation lesions. The totality of data show that routine use of intravascular imaging in PCI reduces mortality substantially. The outcomes after OCT-guided bifurcation PCI appears to be in line with or better than the overall meta-analysis results. So implementing routine OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the effect was shown with 16% ad hoc IVUS in the control arm and despite the COVID-19 pandemic affecting procedural quality and invasive follow-up. Thank you very much.
Thank you so much, Niels. So for the end of our Amsterdam session, we're going to have Dr. Kang come and present us the OCTIVUS, a local study. Looking forward to hearing your recap.
Thank you. This is another study of the imaging-guided PCI that was presented in the ESC last year without previous 2 trials. This is OCTIVUS trial that compared OCT-guided PCI versus IVUS-guided PCI in an all-comer patient. Because the intracoronary imaging-guided PCI with the intravascular ultrasound IVUS or OCT showed superior clinical outcomes compared to angio-guided PCI-guided PCI, like in Renovate complex PCI trial. However, each device had different imaging technologies, region application advantages. However, there was the limited data of the comparative effectiveness of the 2 devices on the guiding PCI. The guideline recommends that as 2A recommendation of the IVUS or OCT. So we designed the trial to compare the clinical efficacy and safety of the OCT versus IVUS-guided strategies in patients who underwent PCI for significant CAD. This is a very pragmatic trial design with just randomized 2,000 patients with any patient undergoing PCI to OCT versus IVUS-guided PCI. The primary endpoint was target-based failure that was defined as the composite of cardiac death, target-based MI, or ischemic-driven TVR at 1 year. Inclusion was we enrolled almost all patients in the cath lab, just excluding STEMI, severe renal dysfunction without renal replacement therapy, and cardiogenic shock or decompensated heart failure with a depressed LVEF under 30%. An imaging-guided PCI was done by the operator's discretion with a standard technique. We used the Boston Scientific IVUS or Abbott OCT, and the stent size length optimization was the common algorithm with we followed the expert consensus. And primary endpoint was, as I commented, the target-based failure. And the power calculation was based on the assumption that the 1 year event rate of the 8.0% in the IVUS-guided group. It was done in 9 the sites in South Korea. And over 3,000 patients were screened, and 2,008 patients was randomized. And over 99% of the patient was followed, and 100% was included in the ITT analysis. And this is the key baseline characteristics that the mean age was about 64, and the female sex was on 21%, and diabetic patient was 33%, and the previous PCI history was in the 21%. And the clinical indication was mainly stable angina. And the treated lesions, the left main was enrolled in the 13%, and any bifurcation disease was present in more than 50%, and mean syntax score was 15. And the over than 60% was treated with the radial access, and over 96% of the patient was treated with drug-eluting stent, and others was treated with the drug-eluting balloon for ISR. And the data shows that the total amount of the contrast media used was higher in OCTIVUS-guided PCI, maybe related to the pullback with the contrast injection. However, the total PCI time was shorter in the OCTIVUS-guided group. Procedural success by the angiography was similar with very high. However, in the base of the imaging guide-based, the procedural success was lower in OCTIVUS-guided PCI group. And procedural complications was very low. And core imaging analysis measured by the OCT group by OCT, IVUS group by IVUS, that showed the minimal stent area was smaller in OCT-guided group with a smaller degree of the minimal stent expansion. And this is the primary endpoint of the target vessel failure. It's 3.1% of the IVUS-guided group and 2.5% in the OCT-guided group. That shows the non-inferiority of the OCT-guided PCI compared to the IVUS-guided PCI. And this is a detailed list of the CV outcomes with the target lesion failure, death, or target vessel MI, or TVR that showed no significant difference between groups. And sensitivity analysis by the per protocol population or age-treated population did not show difference. And the pre-specified key subgroup analysis by the clinical factor like age, sex, DM did not show any difference. Also, the anatomical factors of the left main, bifurcation, severe calcified lesion, or syntax did not show a significant interaction between the anatomical factors and the treatment strategy. And we also performed the entire follow-up. Not all, the 1 year was the primary endpoint, but we extended the follow-up up to 2 years, ranging 1 to 4.8 years for all common patients. Also showed the primary composite outcome for 5.8% in OCT-guided PCI and 6.1% in IVUS-guided PCI. Also showed no difference between groups. The study has some limitation because it was not possible to mask the imaging modalities from the patient and investigators, so there can be some ascertainment or selection bias. And the observed number of the primary outcome events was lower than expected, so several explanations would be possible, but there can be some underpower problem. And there would be the possibility of the discrepancy on site determined and core and measured imaging interpretation, and the generalizability and reproducibility of our trial finding may be potentially limited because of the geographic variability of the use of the intravascular imaging device. And our trial did not include angiography-guided arm. So this is a summary of the OCTIVUS key findings. In this large pragmatic RCT comparing OCT and IVUS of PCI guidance in patients with a diverse anatomical or clinical characteristics, we found that the OCT-guided PCI was non-inferior to IVUS-guided PCI with a primary endpoint of target vessel failure at 1 year. And the incidence of the primary outcome event was lower than expected, possibly due to improvement of the method or technique and general improvement in the cardiovascular care, I hope. And the amount of the contrast dye used during the procedure was higher in the OCT-guided than IVUS group, but it was not related to an increase of the contrast-induced nephropathy. Yeah, thank you for your attention.
Thank you very much for this excellent presentation. And we move on for the number 4 trial, which is also very important, the PREVENT trial, also presented by a colleague from Asan Medical Center, Jung-Min Ahn.
Thank you, Bruno. So my topic is the PREVENT trial. Okay, the vulnerable plaque theories come from the Dr. Müller So he suggests that some plaque, it could be the rupture stimulated by, after sudden stimulation, usually the very early in the morning. In addition, previously we thought that the pleural plaque usually associated with the very mild plaque, but recently the more studies suggest that the pleural plaque is associated with large plaque burden and significant stenosis. So anyway, we presented this preventive trial in this year ACC, preventive PCI first medical therapy alone for treatment of vulnerable atherosclerotic coronary plaques. So this is the background. Intracoronary imaging defined the pleural plaque has more tendencies to increase major adverse cardiac events. Optimal medical therapy is the standard approach to stabilize the plaque vulnerability, but the safety and effectiveness of focal preventive percutaneous coronary intervention of non-flow limiting vulnerable plaque are unknown. So we designed this trial to assess whether focal preventive PCI of non-flow limiting imaging defined vulnerable plaque improves the clinical outcomes compared with optimal medical therapy. This is trial organization. We defined the vulnerable plaque if the patient have angiographically coronary stenosis more than 50% with a negative FFR, means that FFR is more than 0.80, meeting two of following four criteria. One is minimal lumen area less than 4 square millimeter, plaque burden more than 70%, thinking fiber atheroma by OCT or RF IVUS, or lipid-rich plaque defined by the NIRS, lipid core burden index more than 315. If a patient meets this criteria, we randomly assign to the patient to the preventive PCI plus OMT, 800 patient, OMT alone, 800 patient. Prime endpoint is the target vessel failure at 2 years. So this is the inclusion criteria. I already explained that. So during the initial recruitment period of trial, PCI was performed with the bioresorbable scaffold. But following the withdrawal of BVS, the Giants was used for default device of the PCI. Intravascular imaging was performed in all target vessels. Patient received dual antiplatelet therapy at least 6 to 12 months. Clinical follow-up was done 1, 6, 12, and 2 years, and every year thereafter. So follow-up continued annually in all enrolled patients until the last enrollment patient reached 2 years after randomization. Look at here is the intermediate stenosis, more than 50%. So we evaluated the intracoronary imaging, minimal lumen area small, large plaque burden, and thinking fiber atheroma by the RF IVUS, and years show that the significant lipid-rich plaque. And this patient was assigned to the preventive PCI group. We implanted the bioabsorbable scaffold, 3.5 by the 18 millimeters, one stent. Primary endpoint is target vessel failure, a composite of death from cardiac cause, target vessel myocardial infarction, ischemic-driven target vessel revascularization, or hospitalization for unstable or progressive angina at 2 years after randomization. Secondary endpoint is the individual component primary endpoint and other endpoints. Initially we calculate the patient number is 1,600 based on the previous data, the 8.5% for preventive PCI, the 12% for OMT groups. This is the patient flow. We initially screened the 5,000 patients with intermediate stenosis, and only 300 patients with negative FFR. So this is very similar to the previous FFR study. Even though the significant stenosis, 6% around the 40% of lesions excluded by the FFR, negative FFR, but the significant stenosis is 63%. And finally, randomized patient is 1,608 patient after exclusion by the intracoronary imaging study. So 803 patients assigned to the preventive PCI OMT group and followed up to The median follow-up was 4 years, follow-up to 7 years. 2-year follow-up is completed to 97%. The complete follow-up overall is 95%, 100% included in the intention to treat analysis. This is the patient baseline characteristic. Mean age is 64, typical age of PCI study. Diabetes is 30%, and mostly stable angina and silent ischemia. So this is qualifying the criteria. Minimal lumen area small is 97, plaque burden large 97, lipid-rich plaque is 28%, thinking fibrosarcoma is by the IVUS, OCT or the RF-IVUS is only 7%. LAD is the predominant. Diameter stenosis is by QCA is 56. Minimal lumen diameter is 1.3. The lesion length is 23. Minimal lumen area is 2.8. Plaque burden is 76. So this is a procedural characteristics. Some patients have a non-target lesions, 36% of enrolled patient, and then target lesion treatment is drug-induced stent implantation is 67. Initial period we implanted the BVS 33%. The number of preventive PCI stent is only 1. Diameter is 3.5. Total stent length is 23. PCI time is increased around 10 minutes, and total contrast volume increased 50 milliliters. The acute complication is very rare. So this is the high-intensity statin or moderate intensity statin plus ezetimibe therapy. So more than two-thirds of patients received high-intensity statin therapy. So at the maximum follow, the LDL at follow-up was 64 milligram per deciliter. This is similar to the high-dose statin therapy trial. This is the primary composite outcomes. Target vessel failure at 2 years. For OMT alone, is 3.4. The preventive PCI group, 0.4. This benefit is consistent, maintained up to 7-year follow. Another key secondary endpoint was a patient-oriented composite outcome, death from any cause, any MI, and any repeat intervention, significantly reduced by preventive PCI. At 7 years, 14.24% and 19.3%. This is the individual component of primary endpoint. Primary composite endpoint is significantly reduced by the preventive PCI. Death and target vessel MI statistically insignificant, but they show that the same trend reduced by the preventive PCI. Ischemic-driven target vessel revascularization and hospitalization is a major driver to the major driver of the benefit of target preventive PCI, statistically significant. Every secondary endpoint show that the similar trend. This is our analysis at 2 years, and this is 7 years. At the 7 years, 3 components show that the significant P4 interaction, PCI of the non-target vessel, median diameter stenosis by the QCA, and preventive PCI modality, BVS versus Giants. Actually, the preventive trial has the many study limitations. The open label, and so observed rate of primary outcome was substantially lower than expected in both groups. And selection of imaging modality to assess the plaque vulnerability was left to operation discretion. Crossover is acceptable, but the event rate is very low. So I don't believe, but this kind of crossover may affect the overall outcomes. In addition, follow loss is very low, but the event rate is low, so the follow loss may affect the long-term outcomes. Even though this is the key summary of the PREVENT trial. PREVENT trial is the first large-scale randomized controlled study comparing the preventive PCI plus OMT versus OMT alone for treatment of non-flow limiting imaging-defined vulnerable plaques. In the PREVENT trial, preventive PCI reduced the composite risk of death from cardiac cause, target vessel MI, ischemic-driven TVR, or hospitalization at 2 years. Preventive PCI also reduces the composite patient-oriented outcome of risk of all-cause death, any MI, and any repeat intervention. This benefit was sustained throughout the 7-year follow-up period. In PREVENT trial, preventive PCI resulted in the lower incidence of MACE compared with the OMT alone in patients with a non-flow limiting vulnerable plaque. Our key findings might provide novel insights on the role of preventive PCI on non-flow limiting high-risk vulnerable plaque in the future. So the preventive PCI, PREVENT trial, I think, opened the door of preventive PCI of vulnerable plaque. Thank you for your attention.
Thank you, Jung-Min. You can stay up, actually, since Jung-Min, you want to stay up? So this session is now open discussion. Please come approach the microphone and ask questions. I'm going to start. So Jung-Min, let me ask you a question about the blinding of the patients in PREVENT, okay? So if the patients know that there's a 2-year clinical endpoint, they have follow-up at 2 years, there's a sudden rise in the preventative PCI group at 2 years where there's a catch-up phenomena. Did the patients know which group they were assigned to?
They didn't. Actually, they knew that the enrollment of clinical trial, but I don't think my patient is smart enough to remember that their assignment, I think.
And what about they're coming back to the physicians now. Were the physicians blinded to the follow-up?
Yes.
Right.
Yeah.
Okay, great.
So
The reason I ask, of course...
Catch up after the 2 years, we can explain that the first is the polar plaque, the risk is not steady. There should be a temporary change. Time goes by, the polar plaque sometimes stabilized, but the different location of coronary artery, the polar plaque can happen. So the other is that because of the preventive PCI device, we compare to the BVS and Giants. So BVS show that the late catch-up rapidly after the 2 year. That caused this kind of late catch-up phenomenon in the preventive PCI group.
If I can ask.
Please.
No, not to Jung-Min, but I have a question to Dr. Hong.
Yeah, please.
Okay. So when you advance imaging catheter through the side branch, especially after a 2-stent procedure, you sometimes need additional maneuvering, requiring additional fluoro time, procedure time, and contrast. What's the procedure time difference between those two groups and the contrast used?
Yeah, so it was quite substantial difference. These were very complex cases. Although we had many surgical turndowns, very high syntax score patients, and so we had a contrast use in the angio arm of 200 mils compared to 300 in the OCT arm. So quite substantial difference. Some of it is due to the OCT acquisition, but some of it is also due to the additional optimization because you realize you need to do more, you get longer procedures so actually OCT part of it was not that much, but the additional optimization that you need to do in planning additional stents, more balloon inflation and so on, also took additional time. So it's a mix of those effects, but it does result in longer procedures. We also had some that was not that far on the learning curve on OCT and ended up in very complex procedures with it.
Thank you.
I have a question for Ziad and Niels together. So my understanding is that both trials were impacted by the COVID pandemic. What would you have expected if this COVID would not have been there? Would have been the differences been bigger in the trials, or would you have shown a significant difference in hard endpoints? What do you expect?
Well, I mean, all I can say is that we spent an enormous amount of time powering this trial. We actually created a meta-analysis of each individual complex lesion and complex patient, then pooled them and weighted them to create our sample size. And so if you noticed in our analysis in the patients who were enrolled pre-COVID, that was exactly where we were. And then, as I mentioned, the main impact, as we all know, of these trials is ischemia-driven target vessel revascularization, comprises about 70% of all the endpoints, just like it did in Prevent as well. And so when you squash that accordion, you eliminate or you make it much harder to be able to detect differences between the groups, because we went from an 8% revascularization rate before COVID to a 4%, basically because people weren't going to the doctor and they couldn't get a revascularization. And so my expectation would be that we would have seen a result very similar to Renovate, very similar to IVUS-XPL, very similar to Ultimate. And what makes me even more confident in saying that is if you look at the hard endpoints, the things that aren't influenced by the fact that you can't go to the doctor or don't have access to care, they're exactly where they should be. So those were the things that sort of provided us some solace that there would have been a similar finding.
I can only echo what Ziad says. I think maybe we just had a bit larger effect size because our patients were more complex. But in reality, it's the same. We could see from the hard endpoints, they were exactly as expected. And we had probably also expected an effect was slightly larger in the overall cohort. We didn't get that. But at the end of the day, well, now we have results. We need to look at the totality of the data. And it's compelling that intravascular imaging reduces all-cause mortality, cardiac death, myocardial infarction, repeat revascularization. So we are past the point where we need to discuss these things. We are there where we need to look at how do we implement this, how do we get it into clinical practice.
I would just say one more thing to that, and that is if I was going to redesign this trial, I would not include complex patients because the hazard ratio is almost 1. You can't, intravascular imaging can't really help you be less diabetic, right? It can really help at the lesion level because what you can see, you can fix. So it's a camera, essentially. And the second thing is we should have stratified by lesion length. And actually, because we had almost 60% of our complex lesions, or patients, and 80% of our complex lesions ended up being long lesions with multiple stents. They were easy to enroll. And so those aren't as hard as we thought they were in 2016.
Ziad, I have a question. I'm trying to make sense of your comments versus what we think normally is. When we teach our fellows about left main stenting, we always say, oh, do a pre-procedural, do an IVUS before you decide on what you're gonna, what strategy you're gonna go forward with. So my feeling is using an imaging procedure. There's the group that pre-stenting. You sort of base your strategy on the pre-stenting image, and that's where it really helps. Versus there's a group of lesions where it's you stent it and then you see whether you did your best job, and you figure out if you need to post-dilate or to what degree you need to post-dilate. So do you think we need to maybe going forward to try to tease this out and see which lesions are better for what, for what purpose? I just want to hear your opinion. Dr. Jang, if you can.
I mean, I'll keep this very brief. For me, if you open the catheter and you paid for it, you'd be silly for not to use both, right? To do pre if you can cross and post if you couldn't, because it's just like a TAVR, right? You don't want to get to your TAVR and then ask for the valve and somebody go get it, right? You want to be there and say, look, I need this stent, this post-dilation balloon, everything is streamlined, the procedure goes quicker, and you have a plan.
Along those lines, though, Ziad, I was noted that you mentioned that stent length was an independent predictor of death or MI. And do you think, and so presumably I meant that means like, more stents or longer stents. And so is it that pre-PCI we're putting in longer stents with OCT, or is it that post-PCI we're identifying dissections and adding a second stent, or do you have a sense of that?
So that's a really astute question. The reality is that in almost every analysis we've ever done, the reason stent length ends up being a predictor is lesion length, right? But they're collinear. And as they're collinear, the stent length always comes out in the hazard ratio or in the coefficients is a little bit higher. So as you can imagine, if you've got more disease, you're more likely to have an event. So I don't think it's an independent effect of the stent length. I think it's much more likely an independent effect of the lesion length. So you have more plaque. Peter, you had something.
Yeah. I have still a question in line of the previous questions. I wonder, which imaging run is for you the most important one? Is that the pre or is the post? I think in ILUMIEN 4 you try to figure out what was the major decision taken based on your imaging. So in order to have a better adoption of intravascular imaging guided PCI, I would like to know which procedure, is it pre, is it post, or is it periprocedural? Which one is the most influential for your outcome?
So I can just
Yeah,
give you my opinion, or okay, you
Yeah,
want?
no, I totally agree. I found pre-procedural OCT helps so much to develop your own strategy. You get all the information, including reference diameter, length of the lesion, but also plaque characteristics. So based on that information, you can develop your own strategy.
I'll add just one small comment to that. When we looked at all the patients who had pre-PCI decision-making versus post-PCI decision-making, you always put a smaller stent or smaller maximum balloon to size if you only optimize post. And the reason is, nobody goes from a 3 millimeter post dilation to a 4 millimeter. You go from a 3 to 3.5. And so if you put a bigger stent in originally because you sized properly, then you usually go up one balloon size post. So when we looked at this in ILUMIEN 3, we found you use a half a balloon size larger if you use post imaging compared to pre.
2 short questions and we have to move on.
Yeah, I have 2 questions, one for Dr. Ahn and one for the panel. So Dr. Ahn, you mentioned you didn't do the cost effectiveness analysis in the study.
We didn't do.
Yeah, is there any plan to do a post hoc cost effectiveness analysis?
No, we didn't gather the data of cost and effective, so we cannot do.
Sure, thanks.
Yeah.
And the question for the panel is, we have the results of ischemia and now the PREVENT. So what's your message for a clinician? I mean, how should they approach the treatment on the basis of the 2 studies?
Dominick, what do you think?
Well, I don't think they're necessarily mutually exclusive here. We have an innovative trial such as PREVENT, which is in line with the pathophysiology and what we would think to do clinically. So I just think it just adds on to what we know from ischemia.
Actually, I gave a talk yesterday on that topic. Well, if you can play the record.
Frankly speaking, I totally agree with your Ik-Kyung's opinion. So we just opened the door. So we need the more data and following clinical trial. So in the future, we can see which strategy would be good. But anyway, we have both hands, 2 hands. One hand is ischemia, the other hand is PREVENT. Thank you.
Fantastic discussion. Unfortunately, we have to move on. We have now a pre-recorded talk from Greg Stone. It's about the relief.
Hi, this is Greg Stone from the Icahn School of Medicine at Mount Sinai in New York City. And it's a pleasure to speak to you today about the principal results from the RELIEVE-HF trial, which was a double-blind, randomized, placebo procedure-controlled trial of an intratracheal shunt in patients with heart failure across the spectrum of left ventricular ejection fraction. These are my relevant disclosures. So heart failure is characterized by an increased left atrial pressure and pulmonary venous congestion, regardless of the ejection fraction. Left atrial pressure is known to rise with exercise and fluid overload and may be difficult to control pharmacologically. The concepts existed for a long time that a small communication between the left and right atrium created by an intratracheal shunt may provide an autoregulatory mechanism that's on 24/7, 365 to decrease left atrial pressure as it rises and improve heart failure symptoms and prognosis. In pilot studies, the Ventura interatrial shunt, which is manufactured by V-Wave, reduced filling pressures, improved cardiac structure and function, and provided symptomatic relief and functional improvement in patients with heart failure and reduced as well as preserved ejection fraction. This is the V-Wave shunt. It's a hourglass-shaped device. It's quite small. It's about the size of a dime. It has a small orifice of about 5.1 millimeters in the center of it. It's implanted in the fossa ovalis, and it creates a shunt with a pulmonary to systemic flow ratio of approximately 1.2 to 1, allowing about 1 liter per minute of blood flow rather than going forward to be transmitted from the left atrium to the right atrium. So we did a large-scale prospective randomized trial in which we included patients with established cardiomyopathy with any left ventricular ejection fraction. They had to be on all Class 1 guideline-directed medical therapies and cardiac rhythm management as assessed by a central eligibility committee with heart failure specialists. They had to either be hospitalized for heart failure within the prior year or have an elevated natriuretic peptide level. They had to have reduced 6-minute walk time. The major exclusion criteria were either severe pulmonary hypertension or moderate or severe right ventricular dysfunction. And we also had a final exclusion assessment in the cardiac catheterization laboratory, usually with transesophageal echo and right heart catheterization, to make sure that there were no interatrial septal abnormalities and no hemodynamic instability. So this is the overall patient flow of this trial. 1,136 patients were screened, from which 605 were eligible, and after a roll-in phase, we randomized 508 patients in 94 sites around the world over a 4-year period, 1-to-1, to receive either an intratracheal shunt or a placebo procedure. And the patients were deeply sedated, they wore masks, music-playing headphones, and neither they nor their families nor any physicians or research personnel or anyone who interacted with the patient after the cath lab knew the randomization allocation. Now, importantly, because we didn't know whether the response to an atrial shunt would be similar in patients with heart failure and reduced and preserved ejection fraction, we stratified the randomization according to a core lab assessed LVEF less than or equal to versus greater than 40%. We followed the patients for up to 2 years, at the time of which the last patient had 1-year follow-up. There were very few patients that withdrew or were lost to follow-up, so the median follow-up was about 22 months. This is the primary safety endpoint, which was the 30-day rate of device-related or procedure-related major adverse cardiac or neurologic events. And this was only in the intratracheal septum, intratracheal shunt group, compared against an objective performance criteria, and this occurred in 0 patients. So it easily passed our safety endpoint, and in fact, through 2-year follow-up, there were no device or procedure-related major adverse cardiovascular or neurologic events. The primary effectiveness endpoint was a composite hierarchical ranking of 4 hard cardiovascular outcomes, all-cause death, heart transplantation or LVAD, all heart failure hospitalizations, and all outpatient worsening heart failure events, followed by a quality of life improvement, change in KCCQ, assessed by the win ratio. And in the entire trial, there was no overall difference in effectiveness. You could see the number of wins, ties, and losses at each level of the hierarchy, and the p-value was 0.20. If you look here at just the first 4 components of all cardiovascular events, you could see the rates were almost identical. About 56% of patients every year were having an event, so a high-risk population, but no difference with the shunt. If you break this down into the 4 different components, you could see there was no difference in death, LVAD heart transplant, heart failure hospitalizations, or outpatient worsening heart failure events. Nor was there a difference in KCCQ in shunted patients compared to control patients. You will note, however, that there was a fairly large placebo effect, that all of the patients felt they were substantially better, beginning as early as 30 days after the procedure. You'll notice that the baseline KCCQ was close to 50, which is pretty severe heart failure-related symptoms, and this improved by about 10 points and was pretty stable over time all throughout 2-year follow-up, with no difference between the shunt and control. But where the trial became extremely informative was when we looked at our 1 stratified randomized subgroup analysis, and that was according to left ventricular ejection fraction less than or equal to 40% versus greater than 40%. In those with reduced ejection fraction, and these are separate randomized trials, there was a marked difference in cardiovascular events, much less in the patients who got shunted. In the control group in blue, there were 134 events in 54 patients, or 89% events per year. So very high risk group. And this was reduced at the end of 2 years to 49% per year, a 45% reduction that was highly statistically significant, p-value less than 0.0001, and you note that the curves are still diverging at the end of 2 years. In contrast, in patients with preserved ejection fraction, you could see the exact opposite pattern. First, if you look at the control in blue, they're a much lower risk population because their ejection fraction is normal. They're still having about 36% heart failure event rates per year, and this was increased by 68% to 60% of heart failure events per year after putting in a shunt. And the p-value for this interaction was less than 0.0001, so very, very striking. If you look at the components of these cardiovascular events, you can see in the heart failure with reduced ejection fraction, it was really driven by about a 50% reduction in heart failure hospitalizations with a strong trend towards an 84% reduction in the need for LVAD or heart transplant. But there were also 37% and 30% reductions in both death and outpatient worsening heart failure events that did not reach statistical significance. In contrast, in the patients with preserved ejection fraction, this difference was driven by a doubling of all heart failure heart failure hospitalizations and a statistically significant tripling of mortality, an 11.2% increase in mortality, p-value of 0.004. In contrast to these striking results, there was no difference in KCCQ in either group. All patients basically felt that they were getting better. They all felt better symptomatically, regardless of whether the ejection fraction was reduced, with no benefit of the shunt, despite the fact that the shunt was reducing heart failure hospitalizations by 50%. And in the preserved ejection fraction group, again, all the patients were getting better, with no decrement in the shunt group, despite the fact that the shunt was doubling heart failure hospitalizations and tripling mortality. So this observation really raises questions about the utility of the KCCQ in heart failure trials that are blinded and by implication open label. So in summary, we concluded that transcatheter implantation of the Ventura interatrial shunt was safe, but did not reduce symptoms or improve prognosis through 2 years in heart failure patients across the full range of all left ventricular ejection fractions. However, the results from a pre-specified stratified analysis suggest that interatrial shunt implantation is beneficial in patients with reduced left ventricular ejection fraction and harmful in patients with preserved left ventricular ejection fraction. Thank you for the opportunity to speak to you this year, and next year I certainly hope to see you in South Korea. Thanks.
Okay, great. So moving right on, I'm pleased to introduce my co-moderator, Bruno Scheller, who's truly a luminary in this field of drug-coated balloons. Bruno, update us on small vessels.
Yeah, thank you very much. It's a great pleasure for me being allowed to speak here. Why are we talking about drug-coated balloons in coronary de novo disease? Because we have device-related event rate, if you implant a stent, which is in the range of 2 to 3% per year. And if you look at, for example, this huge meta-analysis, the diameter of the stent is one of the predictors of device-related events over time. Small vessels are very common. In Germany, for example, this is an old analysis we looked at, about 1/3 of our vessels are 2.75 or smaller. The Basket Small 2 trial was a trial conducted in Germany, Switzerland, and Austria. It was a randomized comparison of drug-coated balloon-only approach with the implantation of a drug-eluting stent. When the trial was initiated, it started with the Taxus Element drug-eluting stent. Then this was taken off from the market, and the majority of stents were then the Exine stent in the later course of the trial. In total, 883 patients were assessed for eligibility. All these patients underwent pre-dilatation of the small artery, and in case of not achieving the goal of an acceptable angiographic result, which means flow-limiting dissection or residual stenosis more than 30%, those patients underwent stent implantation and went to the registry, 125 patients. At the end, 758 patients were randomized either to DCB treatment or to drug-eluting stent treatment. These are the baseline data. No real differences between the groups. We had a large number of patients with multi-vessel disease, which is one thing we have to discuss maybe later, and relates to the outcome of the trial. This was the outcome of the primary endpoint, major adverse cardiac events. And as you can see, within the first year, there was initially a slight benefit by DCB treatment, but at 1 year there was no difference at all in the event rate. The criteria for non-inferiority were reached. This is the 3 years follow-up, and again you can see that the curves are very similar, with very similar outcomes at 3 years, both for the drug-coated balloon concept, also for the drug-eluting stent. This was a little bit disappointing for us because we expected that we would have similar event rates at 1 year and maybe a separation of the curves afterwards. There were some discussions about mortality because we had numerically within the first year a higher death rate than it was the case in the stent group. And then we looked in more detail in those patients. And the interesting thing was that the majority of those patients in the DCB group had additional stent implantation around the intervention. And the reason was that it was allowed to treat other lesions that were, and most of them were in larger vessels and were treated with drug-eluting stents. And this is because we had so many patients with multi-vessel disease, and this may be one explanation why we do not see a real effect of avoiding stents in the small vessels, because the events are mostly triggered by the larger vessels. This is the data from the angiographic sub-study. Those patients who underwent control angiography were compared, and as you can see, there was no single vessel closure in the DCB group, but a relevant number of stent closures at follow-up, but they were mostly clinically silent. But this shows that this risk of vessel closure when you do not implant a stent is not existing or was not existing in this trial. Then we had several pre-specified subgroup analysis, for example, diabetics versus non-diabetics. And here you can see the highest event rate was in the diabetic patients with drug-eluting stent implantation, whereas the other subgroups had no significant differences in outcomes at 3 years. This is the analysis for acute coronary syndrome versus chronic coronary syndrome. And here you can see there is at least numerically a benefit in the ACS patients by using the drug-coated balloon, which was not the case in the chronic coronary syndrome patients. And this difference was mainly driven in the ACS patients by a difference in myocardial infarction. The next analysis, subgroup analysis, was on patients with and without chronic kidney disease, and here you can see there were no relevant differences. However, there was at least some trend towards less major bleeding events in the DCB-treated patients compared to the drug-eluting stent group. We also looked at patients at high bleeding risk, and again here no differences between the groups, with the exemption that the event rates in the high bleeding patients were a little bit higher. But here again, at least a trend towards less bleeding complications in the DCB-treated patients compared to the drug-eluting stent group. So Basket Small 2 is the largest published randomized trial comparing DCB only and drug-eluting stents so far. The definition of small vessel can be discussed because it was at the end of the day less than 3 millimeter in diameter. DCB only was non-inferior to drug-eluting stents at 1 and 3 years in terms of MACE. We had no vessel closures in the angiographic subgroup in the DCB only group. The possible advantages of this concept were masked by a relevant number of large vessels treated with drug-eluting stents in both groups. The potential advantages of DCB only in predefined subgroup were that we saw a reduction of MACE in diabetic and ACS patients and a reduction of bleeding events or trend to it in CKD and HBR patients. Small vessels are the best accepted indication after instant restenosis for drug-coated balloons. However, the real benefit of DCB only will only become apparent in the treatment of large vessels with more significant impact on hard clinical endpoints. Thank you very much.
Thank you, Bruno. So we're going to not shift off drug-coated balloons, but shift off coronaries into the peripheral circulation. And we're going to hear Dr. Ko, who's going to talk to us about the use of IVUS versus angiography guidance for the outcomes of drug-coated balloons in the treatment of peripheral vascular disease, specifically femoral popliteal disease.
Okay, thank you for kind invitation. This is the study results presented at ACC this year. These are my disclosures. This is a study funded by Medtronic and Korean United Pharmaceutical. Drug-coated balloons have demonstrated favorable clinical outcomes in treating femoral popliteal artery disease. However, challenges such as vessel recoil, residual stenosis, and arterial dissection remain significant limitation of DCB treatment. Thus, improved vessel preparation and post-DCB optimization are needed to enhance endovascular treatment outcomes. Intravascular ultrasound provides detailed information on vessel dimensions and plaque characteristics. However, there have been limited clinical data on the clinical benefit of the IVUS in the endovascular treatment of femoral popliteal artery disease using DCBs. Therefore, the study purpose was to investigate the clinical advantage of IVUS-guided DCB angioplasty for femoral popliteal artery disease by comparing the outcomes of IVUS-guided versus angiography-guided DCB angioplasty. So this is the study design of IVUS DCB trial. So it was investigator-initiated trial designed as multicenter RCT to test superiority of IVUS guidance over angiography guidance. A total of 237 patients with symptomatic femoral popliteal artery disease with Rutherford category 2 to 5 from 7 centers in Korea were included in this study. These patients were randomly assigned in a one-to-one manner, either to IVUS guidance or angiography guidance after stratification based on the enrolling site and lesion length with a cutoff of 150 millimeters. There were 3 cases of crossovers, 1 in the IVUS guidance group and 2 in the angiography guidance group. And all lesions were treated with DCBs from the impact DCBs from Medtronic, and we followed this patient for 12 months. These are the institutions and investigators of IVUS DCB trial. These are the key inclusion and exclusion criteria. So inclusion criteria were age over 19 years and the symptomatic femoral popliteal artery disease. And exclusion criteria include acute limb ischemia, age over 85 years, life expectancy less than 1 year, and previous bypass surgery or stenting in the target femoral popliteal artery and untreated inflow lesions. These are the endpoints. Primary endpoint is defined as primary patency. It was defined as absence of clinically driven target lesion revascularization or binary restenosis on imaging studies at 12-month follow-up. And secondary endpoints include freedom from CDTLR and sustained clinical improvement, sustained hemodynamic improvement, mortality, major amputations, and major bleeding. These are the method of procedures. So randomization was performed after successful wire passage. All lesions were routinely predilated except for cases treated with vessel prep using atherectomy. And pretreatment and post-lesion optimization, as well as the choice of device sizes, were left to operator's discretion. IVUS was performed before and after the use of DCBs and the final treatment. No specific IVUS goals were recommended for the IVUS guidance group. All lesions were treated with impact DCBs, and dual antiplatelet therapy was required for at least 90 days post-procedure. all procedural and follow-up images were analyzed at center core labs by independent experts. These are the baseline clinical characteristics. All the characteristics were well balanced between the two groups. So the mean age was about 70 years old, and the majority of the patients were male, accounting for 85%. And diabetes were present in about 60%, and chronic kidney disease were present in 16 to 24%, and hemodialysis patients were included in 6 to 11%. And the majority of the patients had claudication, accounting for 75% in both groups, and procedural ABI was similar between the two groups with 0.6. These are the lesion characteristics. These are also well balanced between the two groups. Most of patients had complex lesions defined as tasks 2C or D lesions, and the lesion length was over 200 millimeters, very long lesions, and total occlusions was present in in approximately 60%, and poor distal runoff was present in 25 to 30% of cases. These are the procedural data. The subintimal approach was performed in 26% of cases, and atherectomy was required in over 30% in both groups. However, even though the DCB diameter was similar between the two groups, the pre-balloon diameter was higher in the greater in the IVUS group, and the IVUS group required higher maximal pre-balloon pressure, and also IVUS group required more frequently adjuvant post-dilation, and the balloon pressure for the post-dilation was higher in the IVUS group. And bare-out stenting showed no significant difference between the two groups. However, numerically, there were more bare-out stenting in the IVUS group. The post-procedural minimum lumen diameter was greater in the IVUS group, and post-procedural diameter stenosis was smaller in the IVUS group. And this is the immediate procedural outcomes. Technical success, as defined as residual stenosis less than 30% without flow compromise, was significantly higher in the IVUS group. And procedural success, defined as technical success without any acute complication, was also higher in the IVUS group. The dissection, the instance of dissection and pattern of dissection were similar between the two groups. The complications showed also no significant difference between two groups. Post-procedural ABI was higher in the IVUS group. So we can say the IVUS group was achieved better immediate results. And these are the clinical outcomes at 12 months. So the primary endpoint, the primary patency, was significantly higher in the IVUS group with 87% versus 70% in the angiography group. And also secondary endpoints, including freedom from CDTLR, sustained clinical improvement, sustained hemodynamic improvement, were also significantly higher in the IVUS group than in angiography group. Complications and safety endpoints showed no significant difference between the two groups. And this is the Kaplan survival curve for the primary patency at 12 months. Intention to treat analyze showed there was significantly higher primary patency in the IVUS group compared to angiography group. Also, per protocol analysis showed similar results. And this is the freedom from CDTLR. ITT analysis showed significantly higher freedom from CDTLR in the IVUS group compared with the angiography group. Per protocol analysis showed also similar result. And we look at the subgroup according to the task 2 lesion types. In the simple lesions defined as task A-B lesions, there was actually no significant difference in the primary patency between the two groups. However, in the complex lesions, such as task 2C or D lesions, IVUS group showed significantly higher primary patency compared with angiography group. Since the use of IVUS and the post-procedure MLD showed the so-called linearity, so we applied two models of multivariate analysis. In the model, including use of IVUS, showed the predictors of restenosis as lesion length longer than 200 millimeters, subintimate approach, and use of IVUS. And in model 2, including post-procedural MLD, showed the lesion length and post-procedure MLD as significant predictor of restenosis. So in conclusion, IVUS guidance significantly improved the outcomes of DCB angioplasty for femoral pulpity artery disease in terms of primary patency, freedom from CDTRR, sustained clinical and hemodynamic improvement at 12 months. The benefit of IVUS guidance for primary patency after DCB treatment was more evident in complex femoral pulpity artery lesions. Thank you for your attention.
So seeing as our last lecture is actually going to be a recording, I thought what we'll do is just take a second to summarize these current trials. Dr. Cole, I have a question. One of the things in your study was that you didn't actually have a protocolization of the IVUS, of how to use it pre and how to use it post. So a couple questions. One is, did you train the operators at all on what they should be looking for the IVUS? And then second, what do you think the mechanism is of the benefit of the use of IVUS?
Yeah, so the operators are all interventional cardiologists, and they are all familiar with the use of IVUS. And actually, we did not provide any guideline for the IVUS targets. So the operators, they decided their procedure on their own. And I think as I presented in here, the acute results were better in the IVUS group than in the angiography group. I think that the results translated into better outcome at 12 months.
Along those lines, actually, I wanted to ask Bruno, in the basket small 2, how much intravascular imaging or physiology, for that matter, was used to guide the optimal DCB, and how you make the decision from a practical standpoint when to convert to stenting?
So there was no recommendation at this time, and you have to be aware that in Europe, intravascular imaging is used in 15% or less. We thought about having a sub-study with imaging, but the centers did not contribute enough patients for this. So this was a pure angiography-based decision making in this trial, and we did also not record functional measurements in this study. This is one of the big limitations we have.
In a sense, maybe that's encouraging that you could maybe even get better results if applied that.
I mean, that's one of the interesting questions. We have very elegantly seen that at least in the periphery, you can improve DCB outcomes in complex lesions, as we have seen in this trial. In the coronaries, we do not have any data so far. There is some groups are generating now this data. The problem is that if you see the dissections you create by angioplasty alone, you tend to have a higher stent rate, of course. And that's the question is this a good thing or not a good thing? This has to be answered in the future.
Yeah, I mean, I know there's been some interest in physiology too to guide things, and if you have an optimal physiologic result.
The key question is, I mean, for the stents, it's clear. If you implant a stent, you have to optimize the stents, and there is imaging is the perfect tool. If you do balloon angioplasty alone, where you leave an uncaged vessel, which can have vasomotion afterwards, the question is, do you really need this perfect result, which is fixed by the stent in terms of a cross-sectional area, for example, or is it fine to have a good flow and the vessel can adapt itself in the future? That's a really open question.
So let me ask another question to Dr. Ko, and that's about the subintimal tracking. So interestingly, in the coronary space, we feel like actually perhaps the larger dissection and the elution or distribution of paclitaxel into the media adventitial space actually provides us a positive remodeling. But in your study, which of course everybody got a drug-coated balloon, that it was still a strong and independent predictor of poor outcomes. In the studies to date that are compared to just a regular balloon, not drug-coated, do you find the same findings in the periphery of positive remodeling using paclitaxel-coated balloons, or no?
Actually, there is no objective data about that. So this is only my feeling. So patients who were treated with subintimal angioplasty is more likely to develop dilation in follow-up. But I think the true aneurysmal change is rare. So there has been reported, more instance of, halo sign or aneurysmal change in the use of, in the group of IVUS for the DES treatment it was reported by the Japanese group. They say maybe they're treated more aggressively, the lesion using IVUS. So that may cause, more injury, and they may, lead to, development of aneurysmal change in the IVUS group. But, it was just registry data, and there's no objective, evidence. Yeah.
Bruno, let me ask you a question about the sort of zero acute closure rate. Do you think that's an effect of drug elution, or do you think that's effect of current generation technology balloons? I mean, we don't do that anymore. We don't use balloons and just generally dilate and look for acute closure. Is this a drug biological effect, or is it just a sign of the times of much better angioplasty?
There are two things. Number one, we excluded all patients with not satisfying pre-dilatation result. So this means if you do if you do lesion preparation in every case, you select your lesions that are suitable. That's number one. Those who are at risk for closure go to stenting in every case. That's number one. Number two is I started my as physician in training in 1994. At this time, stents were implanted, and there was unfractured heparin with at a very high dosage and coumarin treatment, and we had a high acute and subacute stent closure rate, 10% plus minus. And then it was changed to dual antiplatelet therapy with ticagrelor and aspirin, and everything, the nightmare was over. Stents were safe from this day on. And nobody looked at the effect of dual antiplatelet therapy in balloon angioplasty alone. So I think that's the pre-selection of the lesions plus the use of DAPT makes this approach safe.
I have a question for Bruno and for Dominick. So the DPT regimen post DCB is now, according to the guidelines, something like 3 months. But if we did POBA, we only gave 1 month DPT. So why should we give 3 months, and should we go, and can we go back to 1 month or less?
We are doing 1 month, so okay. We do not do 3 months.
Although you're doing 1 month, I would advocate that a little bit longer may be better. So Bruno, you alluded to the fact that a lot of the studies did not look at DAPT with the POBA, but when we look at some of the analysis of some of the trials, first and foremost in the CURE trial, nobody speaks about it because it's pretty old. The actual benefit of DAPT was better amongst those patients undergoing balloon angioplasty alone versus the stented patients.
Any other comments or questions? Otherwise, we'll move on to the next session. Or the next? Okay, good. All right, so we're going back to New York, virtual again. It's going to be Roxana Moran presenting a very controversial study. I think this has got a lot of media attention. The SMART trial, which is comparing self-expanding or balloon-expandable TAVR in patients with a small aortic annulus.
Hello, it's absolutely a pleasure to come to you and to report the hot off the press SMART trial, the self-expanding or balloon-expandable TAVR in patients with a small annulus. It's important for you to note my disclosure specifically to this presentation that I am one of the co-principal investigators of the SMART trial supported by Medtronic. Women with aortic stenosis have a higher long-term mortality than men. And I know it is surprising to you, but it is probably because women with aortic stenosis present at a later age. And when they do present, and they are obviously living longer than men, and by the way, they have many comorbidities. They're often frail, they often have small annuli, and of course have some important issues. The pathobiology of aortic stenosis is very different between men and women. While they have the same hemodynamic severity of aortic stenosis, women have less calcification, higher fibrosis score, smaller annulus, and very, very different concentric remodeling rather than eccentric remodeling that's seen in men. Importantly, the challenges are there. Female sex is associated with a smaller annulus as well as the left ventricular outflow tract, but the aortic dimensions are similar. So, really important arena of small annulus, where the aortic valve annulus is less than or equal to 430 millimeters squared. That's how it is defined. It's about 30 to 40% of our patients undergoing TAVR. It is much more common in Asian subjects, as well as women, representing about 90% of those patients presenting with aortic stenosis and a small annulus. What's very important about this, that there is a higher risk of aortic valve gradients after TAVR with a small annulus, and therefore having patient prosthesis mismatch. Let's not forget that women in clinical trials and even in TAVR, even though we were very happy to see 50% enrollment in the early studies of high risk, when we got to the lower risk, women were underrepresented. So let's understand that we continue to be underdiagnosed, underrepresented in clinical trials, the sex-specific data being underreported, and it's limiting our potential to actually improve a woman's health. And it is for all these reasons that the self-expanding versus balloon-expandable TAVR in patients with aortic stenosis and small annulus was designed. These are the primary outcomes from the randomized SMART trial led by Howie Herman and others, many smart investigators. Supraannular expanding, self-expanding evolute has been shown to have superior hemodynamic properties compared with the intraannular balloon-expandable SAPIEN platform. The valve performance is linked to longer-term outcomes, and these hemodynamic differences may be particularly important in patients with a small aortic annulus, which comprises about 40% of patients, typically women, who are underrepresented in clinical trials. Compared with when aortic stenosis presents differently and at higher risk of complications. So this trial was designed to compare the performance and the safety of the supraannular self-expanding evolute valve to the intraannular balloon-expandable SAPIEN valve in patients with severe aortic stenosis undergoing TAVR for symptomatic aortic stenosis and a small aortic annulus. This was the fantastic, extremely diverse executive steering committee and an independent patient case planning committee that made sure there was equipoise for both of these valves to be implanted in the patient on a one-by-one basis before they were enrolled and randomized. There was also an independent CEC and data safety monitoring board, an echocardiographic core lab at the Mayo Clinic, angiography at the BAME Institute, and the statistical analysis was performed by sponsor Medtronic. We had 83 sites in 13 countries representing the globe. You could see them all represented here. Unfortunately, Asia was not included here. This was a prospective, randomized, controlled post-market trial conducted in these 83 sites, symptomatic severe aortic stenosis, small annulus less than or equal to 430 millimeters squared by MDCT, randomized 1-to-1, but stratified by site and sex. That's really important. 716 patients treated, 355 in self-expanding valve, 361 in balloon-expanding valve, with the two co-primary endpoints of clinical and bioprosthetic valve dysfunction. The first co-primary endpoint was composite of mortality, disabling stroke, heart failure hospitalizations through 12 months. The second co-primary endpoint, just as important, both powered, was bioprosthetic valve dysfunction through 12 months. As you could see, 737 patients were randomized, and finally, with the implanted self-expanding valve 350, implanted balloon-expandable valve 365, 98% completed follow-up at 12 months trial visit. This includes the hemodynamic assessment. The statistical methodology is here. The clinical outcomes for co-primary endpoint was powered for the clinical outcome of non-inferiority with a margin of 8% in an as-treated population with the first attempted device with a KM estimates with risk difference of with a 90% confidence interval 12 through 12 months, 85% power for 700 patients. In the co-primary second endpoint, the endpoint number 2, this was bioprosthesis valve dysfunction through 12 months, defined as hemodynamic structural valve dysfunction, mean gradient being greater than 20 millimeters of mercury, severe PPM using VARC-3 definition of non-structural valve dysfunction, or greater than or equal to moderate total aortic regurgitation. We also looked at clinical valve thrombosis, endocarditis, as well as aortic valve reintervention, and this was powered for superiority in the implanted population with the final valve that was received for the patient with these KM curves. We had over 99% power with 700 patients. It's important that the hypothesis tested secondary endpoints, both primary, and if both primary endpoints were met, there was hierarchical testing of secondary endpoints in a pre-specified order powered for superiority, including hemodynamic mean gradient, effective orifice area, hemodynamic structural valve dysfunction, BVD in women through 12 months, as well as moderate to severe prosthesis patient mismatch. The baseline characteristics are listed here, predominantly women. For the first time, almost 90% women were included with an average age of 80 years with an STS PROM score of about 3.3. The valve sizes are listed here. You could see that the mean area for both self-expanding and balloon-expandable valve were pretty much equal, with the mean perimeter of about 70. And you see the valves, distribution of the valves that were implanted with each one. The procedural characteristics are important to note. Self-expanding valve took longer time in the procedure room, longer time in the body, more contrast volume. There was a trend towards more valve embolization, and importantly, device success at 30 days using VARC-3, the self-expanding valve was significantly higher, as well as the device success using VARC-2 and VARC-3 for both of those compared to balloon-expandable valves. Very important are the co-primary endpoint number 1, powered for non-inferiority for mortality, disabling stroke, or heart failure hospitalizations. We met this non-inferiority, no difference. The non-inferiority margin was met, and this was for pretty much the composite endpoint, and as you could see, no differences in disabling stroke, all-cause mortality, or heart failure hospitalizations. Bioprosthetic valve dysfunction through 12 months was very, very different. Here, we were powered for superiority and met this endpoint for superiority for the self-expanding evolute valve, much, much lower rates of BVD through 12 months, 9.4% versus 41.6% for the balloon-expandable valve. And you could see this, all of these met the superiority endpoint for non-structural or structural valve dysfunction, as well as, very importantly, those 2 endpoints for BVD. If you look at the pre-specified subgroup analyses for the co-primary endpoints, No differences in the clinical outcomes between the two. You could see no matter what subgroup you looked at. But in the BVD, pretty much every subgroup, age, sex, risk, LV function, renal dysfunction, atrial fibrillation, pretty much for every subgroup, SEV was better. And there was no important secondary interactions. There was hypothesis-tested secondary endpoints. These were the mean gradient, significantly better for SEV, lower for the self-expanding evolute valve. The effective orifice area at 12 months, better, larger for the self-expanding valve, as was the HSVD, BVD in women, as well as moderate to severe PPM, all better, lower rates of PPM, lower rates of BVD in women, and lower rates of structural valve dysfunction. Additional safety outcomes are here. Pacemaker implants were numerically higher, but not statistically significant. The reason was that the cusp overlap technique was used pretty much in 90+% of the cases in the self-expanding valve, and you could see that these were not statistically different and lower than what's been reported in the past. Importantly, acute kidney injury, despite higher contrast volume use, was no different between SEV or balloon-expandable valve. And you could see the rest of these listed here. Other important hemodynamic endpoints was that the DVI, or Doppler velocity index, through 12 months being higher, mean being higher, significantly higher for self-expanding valve, evolute, as well as severe PPM being much lower, 3% versus almost 10% in self-expanding valve. And total aortic regurgitation, anything more than mild total aortic regurgitation at 12 months was significantly lower for the self-expanding valve compared to the balloon-expandable valve. There were also other definitions used to be sure that we were online, and pretty much every definition, whether it was the ESC, the SMART primary endpoint with the echo only, or the VARC3 endpoint for BVD, all significantly better for SEV, the evolute valve. As well as if we use for HSVD, the O'Hare and the Playford definitions, all better for the self-expanding valve. What's really important is what was the quality of life for these patients. The KCCQ scores seem to be exactly similar between the two, but if you look at the VARC3 KCCQ ordinal outcomes at 12 months, SEV seemed to do better. There was a 75% improvement for anything above mild, moderate, substantially improved in the patients who received the self-expanding valve versus those who received the balloon-expandable valve. So in summary, the SMART trial is the largest, most rigorous trial up to date to randomize patients to two of the most widely used TAVR devices and the largest TAVR trial to enroll mostly women. We met all of the pre-specified important primary endpoints, both, and all pre-specified secondary endpoints were met. And in summary, what we conclude that compared to the balloon-expandable valve, the supraannular self-expanding valve demonstrated non-inferior clinical outcomes at 1 year, superior valve performance at 1 year, with a 32.2% lower incidence of BVD, 8 millimeter of mercury lower mean gradient, 0.5 centimeter squared greater effective orifice area, 0.19 millimeter larger millimeter squared larger Doppler velocity index, as well as 6.8% lower incidence of severe PPM. Improvements on other secondary outcomes at 1 year were also seen, with less total AR and better quality of life using the KCCQ ordinal outcomes. These were all based on the large differences observed in valve performance. We also expect that the SEV will demonstrate improved valve durability on longer long-term follow-up, and this is really what we're looking forward to. Will this translate into superior outcomes that are clinically significant? And I think this is really what we're looking forward to in the next 5 years. So we want to thank all the patients, investigators, research coordinators, and our top enrolling sites listed here. And I can't thank enough on behalf of Dr. Howie Herman, the global PI, and Dr. Didier Cheche, and the entire steering and executive committee. We thank you and have the honor to present these data to you at TCT Asia Pacific. Thank you again.
Great. So we're short on time, but I'm just going to ask a couple of burning questions to Bill. Is this just a numbers game? So, I got to say, they almost doubled the rate of pacemakers, okay, in the self-expanding valve group. You have a higher gradient, but the patient prosthesis mismatch is not driven by aortic regurgitation. It's driven by the same number that drives the gradient. So without a clinical endpoint right now, what does this do for you?
Yeah, well, I mean, I think it's a little discouraging that even in the Evolute arm, 10% of the valves are not, you don't have a successful outcome. So it begs the question, is our definition, are these definitions appropriate? There's such a huge difference in the hemodynamic components that, the definition of valve dysfunction and failure and so forth, yet there was absolutely no difference in clinical outcomes at 1 year. Now, it's only 1 year, but you'd expect, I would think, that you might start to see some difference. But, I mean, I think the proof will be in the pudding. So waiting out until 5 years, I mean, I guess it's encouraging for the self-expanding valve, that there are good signs, but I think many people are going to want to wait until we see differences in clinical outcomes.
It's a little bit like intravascular imaging, right? You end up with a larger minimal lumen area at the end, but does it lead to better clinical outcomes? We don't know yet. So we'll see in 5 years at TCTAP. Thank you very much.